Intubation is the process of inserting a tube called an endotracheal tube down the mouth and into the airway. This is done for a patient to be put on a ventilator to help assist with their breathing. Some indications for this would be the inability to have a patent airway. A patient could have an apnea. They could be hypoxic or in respiratory distress. Contraindication would be airway obstruction. A person with epiglottitis or laryngeal edema, they already have an inflamed and compromised trachea, so inserting that tube would leave very little space for it, and this can worsen their conditions, and it can also result in severe respiratory obstruction.
During intubation, there are hazards. Hazards may include failure to establish a patent airway, failure to intubate the trachea, failure to recognize intubation of the esophagus, upper airway trauma, aspiration, cervical spine trauma, unrecognized bronchial intubation, eye injury, vocal cord paralysis. Problems with the endotracheal tube can occur as well. Things as cuff issues, pilot tube valve issues. The tube could also kink if it is bitten, tube occlusion, bronchospasm, laryngospasm, dental accidents, dysrhythmias, hypotension and bradycardia, hypertension and tachycardia, inappropriate tube sizes, bleeding, or mouth auscultation. Besides hazards, you also need to know what supplies and equipment is needed. These may include an O2 flow meter and tubing, suctioning apparatus, flexible sterile suction catheters, sterile gloves, a Yankauer, manual resuscitation bag and mask, a CO2 detector, a laryngoscope with multiple blades for size, endotracheal tube in different sizes depending on the patient, a tongue depressor, a stylet, a stethoscope, tape or an endotracheal tube holder, a 10 or 12 milliliter syringe, lubricating gel, forceps, an anesthetic spray, towels, and you also want to follow precautions by the CDC, such as a mask, a face shield, gloves, and a gown. We have two different types of a laryngoscope. First is a straight blade known as a Miller. Second is a curved blade known as a Macintosh. Next we have an ET tube known as an endotracheal tube, a small, usually plastic tube inserted into the trachea through the mouth to maintain an unobstructed passageway, especially to deliver oxygen to the lungs. This is the cuff, which inflates the balloon at the bottom of the ET tube or deflates the balloon. This is known as a stylet, which is a device that is rigid that goes inside the ET tube for easier insertion.
This is the syringe. It inflates and deflates the cuff. The average size is 10 to 12 milliliters syringe. This is the capnometry device. It's a disposable CO2 detector. And this is the bag valve mask used to ventilate the patient.
We have two different types of a laryngoscope. First is a straight blade known as a Miller. Second is a curved blade known as a Macintosh. Next we have an ET tube known as an endotracheal tube, a small, usually plastic tube inserted into the trachea through the mouth to maintain an unobstructed passageway, especially to deliver oxygen to the lungs. This is the cuff, which inflates the balloon at the bottom of the ET tube or deflates the balloon. This is known as a stylet, which is a device that is rigid that goes inside the ET tube for easier insertion.
This is the syringe. It inflates and deflates the cuff. The average size is 10 to 12 milliliters syringe. This is the capnometry device. It's a disposable CO2 detector. And this is the bag valve mask used to ventilate the patient.
Select the laryngoscope with the Miller straight or Macintosh curved blade. Make sure the light bulb is tight because it will not light if loose. If the light source is dim or yellowish in color, the batteries are weak and should be replaced. Place the patient in the sniffing position, which is the head above the shoulder level. Select the proper size of ET tube, insert air into the cuff to make sure it holds air, and then deflate the cuff. Insert a stylet into the ET tube to make it more rigid for easier insertion. Make sure the stylet doesn't extend past the end of the tube. Insert the laryngoscope blade into the right side of the mouth and move the tongue to the left. Advance the blade forward. The curved blade should be inserted between the epiglottis and the base of the tongue. With a forward and upward motion, raise the epiglottis to expose the vocal cords. The straight blade should be placed under the epiglottis and lifted upward and forward to expose the cords. As the cords are observed, advance the ET tube approximately 2 centimeters past the cords. Inflate the cuff and listen for equal and bilateral breath sounds. If louder sounds are heard on the right than left, the tube is probably in the right mainstem. Deflate the cuff and withdraw the tube until equal breath sounds are heard. Another method to determine whether the tube is in the airway is by exhaled CO2 analysis, or capnometry. If the ET tube is in the airway, CO2 levels begin to rise. End-tidal CO2 levels are generally around 6%. If the tube is in the esophagus, the end-tidal CO2 reading remains 0. An easier and less expensive method of monitoring exhaled CO2 levels is with the use of a disposable colorimetric CO2 detector on the proximal end of the ET tube. The indicator on the detector changes color when exposed to different CO2 levels. Tape the tube in place and obtain a stat chest x-ray to ensure proper tube placement. The end of the tube should rest 2 to 5 centimeters above the carina. The carina is seen on radiographs at the 4th rib or the 4th thoracic vertebrae.